Hello, everyone. Welcome to Central Pressure Waveform Analysis and Clinical Practice. I'm Mary Hawksworth. I'm the Director of Marketing at Atcor Medical, and we're excited to be kicking off our first webinar in a series with Dr. Lee Marcus. He's the founder of Preventive Cardiology of New York, and he's the Chief Medical Officer of Arterial Health International in Atlanta. Dr. Marcus has been a SphygmoCore user for about a year, and he's speaking today about central pressure waveform technology and his specific experience incorporating it into his practice. We appreciate you being here, Dr. Marcus, and your presentation. A couple of housekeeping items. The webinar is being recorded, and it will be available for playback later. You'll receive a link to the recording via email later today. Also, if you have questions during the session, please submit them through the Questions tab on the GoToWebinar control panel. I'll now hand it over to Dr. Marcus. Thank you.
Thank you, Mary, for that introduction, and I'd like to welcome you all to the presentation, and I'd like to thank the entire crew at Atcor Medical for your support and for providing me with this opportunity to discuss what I feel is a very important topic in cardiovascular disease management today, and one that I fully anticipate that practitioners will be encountering more frequently in the near future and will want to incorporate into their practices to enhance the management of multiple classes of patients at various stages of cardiovascular risk, and that's namely central arterial pressure waveform analysis. So I am a preventive cardiologist, but I think we all as practitioners realize that the physical examinations that we perform on our patients throughout the last 100 years really have not changed much at all. We listen with our stethoscope, we do an EKG, we maybe look down their throat with a tongue depressor, and are we really preventing disease this way, or are we just sort of seeing people with already advanced disease? Is this really the most effective way to manage and evaluate our patients? Well, this same thinking process holds true for blood pressure management. In fact, just as overall medical management of patients is becoming dictated by sound science becoming more personalized, so is the evaluation and management of blood pressure. We can really no longer treat patients by grouping them into boxes based on risk factors alone, because risk factors really are not disease. We don't want to be the physician that tells a patient based on some cohort of patients studied previously that they have a quote-unquote 50% chance of having coronary disease, for example, when in fact we're really telling them that they have a 0% chance or a 100% chance of having disease. We just don't know which class they're in. And this concept is important because we don't want to be treating patients with medications for hypertension that won't benefit from it and exposing them to real risks and side effects. Yet we also want to avoid undertreatment based on inadequate surrogates. And as you'll see, brachial blood pressure is an inadequate surrogate in many patients for assessing true cardiovascular risk. So these are two pressure waveforms taken from two different patients. And although the arterial blood pressure value varies constantly over the cardiac cycle, we really tend to only look at brachial, systolic, and diastolic pressures in clinical practice. And this is a practice, as I said, really which has not changed in over 100 years. It is known, however, that the brachial blood pressure is often a poor surrogate, as I said, for the actual central aortic blood pressure, which is really the true blood pressure that the end organs are seeing, which are the heart, the kidneys, the brain. And it is, in fact, has been demonstrated in numerous studies, both invasively and non-invasively. These measurements are more strongly related to markers of end organ damage, such as LVH and carotid intimomedial thickening, as well as adverse cardiac endpoints than brachial pressure. And as we see in this slide, the patient in red and the patient in blue have identical brachial blood pressures, which I like to think of as the tip of the iceberg. But underneath, their central blood pressures are vastly different and convey different potential risks. The central blood pressure in patient 1 has a much higher pulse pressure at 136/80, and in patient 2 has a central pressure of 115/82. So these will then convey different risk and therapeutic requirements for these patients, and if we were simply to rely only on the brachial blood pressure without looking at this central blood pressure, without looking under the water at below the tip of the iceberg, we would never know that these patients are entirely at different risk. Again, central blood pressure cannot be predicted with any accuracy from brachial blood pressures and must be directly measured. Here we see a Venn diagram from the Anglo-Cardiff 2 central blood pressure evaluation, and showing that the difference in brachial and central blood pressures has significant consequences with respect to treatment decisions. But what we see here is a marked overlap in central blood pressures when patients are stratified into two groups according to either brachial or peripheral blood pressures with stage 1 and versus high normal blood pressures. In fact, about 78% of men in this study and 73% of women in the study with quote-unquote high normal blood pressures brachially had central blood pressures that were indistinguishable from those with stage 1 hypertension. And even more importantly, 32% of men and 10% of women with entirely normal blood pressures, not high normal, but actually normal, had similar central blood pressures to those with already stage 1 hypertension measured brachially. And this raises the possibility, obviously, that those are being classified as normotensive by peripheral blood pressure may in fact be at increased risk due to elevated central blood pressures, and the reverse also may be true. So it may result in undertreatment or overtreatment of patients by not looking at central blood pressure. This study was the CAFE study, and it shows that antihypertensive medications can have differential effects on central versus brachial pressure. The CAFE arm of the greater than 19,000 patient ASCOT study took place at 5 sites involved in the ASCOT study, and it showed differential effects on central and peripheral blood pressure of 2 different medication regimens. That was a prospective evaluation in moderate to high risk hypertensive populations. One group of patients was treated with amlodipine-based therapy with add-on ACE inhibition. The other was treated with atenolol-based therapy with add-on diuretic therapy. A total of about 2,000 patients were studied in this trial, and 95% of the patients ended up on both dual medical therapy, namely atenolol and diuretic, or amlodipine and ACE inhibitor. And with respect to the primary outcome, central blood pressure was significantly lower by 4.3 millimeters of mercury in the amlodipine-based group versus the atenolol-based group throughout the entire study, as we see on the curves. However, this occurred despite no significant differences in brachial pressure. Furthermore, this difference appeared to explain the statistically significantly improved clinical outcomes in the amlodipine-based group with respect to a composite adverse cardiovascular endpoint. Again, brachial blood pressure did not change appreciably or significantly between the groups, but central did, and the outcomes were different, explainable by the central blood pressure differences in the treatment groups. This slide demonstrates that end organ changes appear to parallel central blood pressure changes better than brachial blood pressure changes. And this study compared nebivolol and metoprolol and found them to have similar reductions in heart rate and brachial blood pressure with both medications at a year. But if you look at central systolic blood pressure, nebivolol had a significantly lower, better lowering effect of the central systolic blood pressure, and this correlated with a significantly lower LV relative wall thickness, indicating again that central blood pressure affects end organs much more effectively than brachial blood pressure. And brachial blood pressure, once again, does not indicate the exposure of pressure that the end organs are experiencing. So now I'm going to review some physiological principles regarding the morphology of the central blood pressure waveform and how we can utilize it in the everyday management of patients that we encounter in the office setting. This is a simple graph of the aortic pressure wave contour, and if the arterial system was simply an uncomplicated tube or hose, you'd see the incident wave generated by ventricular contraction that the heartbeat generates, and it travels forward through the vasculature, and the diastolic capacitance dictates the diastolic pressure. It's very simple, simplistic, and it's not based in what we actually see physiologically. Now, because the arterial system is actually far more complex, it's actually a network of tubes, as we know, of diminishing caliber that gradually sort of transform pulsatile flow into continuous flow to nourish our tissues. And the entire network is obviously lined by a very complex endothelial layer, which, I guess expressed simplistically, maintains arterial tone, suppresses inflammation and thrombus formation when functioning normally, serves as a barrier to lipid infiltration and smooth muscle cell proliferation. And all of these factors make the arterial waveform actually far more complex than just the initial slide that we saw previously. In fact, the arterial waveform that we see is a composite of a forward traveling wave generated by ventricular contraction or ventricular ejection, that is the incident wave, and a backward traveling or reflected wave arising from sites of stiffness, bifurcations, and increased impedance mismatch in the peripheral circulation. So the actual aortic waveform represents the sum of both the incident or outgoing wave and the reflected or incoming wave. And you can imagine that the timing of these waves and the amplitude of these waves affects the central blood pressure and subsequently derivatives of that central blood pressure and what the end organs are seeing, and is prognostically significant, as we'll show. So what we see here is that arterial stiffness impacts the morphology of the waveform, and this can have important clinical implications. Again, as I said, the timing of the waves can significantly affect important aspects of the aortic pressure, including the aortic systolic blood pressure, the pulse pressure, which is of key importance because pulsatile flow is actually the key contributor to arterial remodeling, progressive inflammation in the vasculature, lipid infiltration, and even acute events like plaque rupture, stroke, and myocardial infarction. And aortic stiffness indices are derived from these measures. And as we see in the first panel on the left, that late wave reflections result in decreased arterial stiffness. And if the reflected wave due to increased arterial stiffness occurs earlier, the aortic pressure, systolic pressure, is augmented due to a merging of the reflected wave and the incident wave, and you get a higher systolic pressure after a little notch in the upstroke of the systolic pressure wave. So what is the augmentation pressure, as we see on this slide? Well, the augmentation pressure is actually the contribution of the reflected wave to the pulse pressure, and it is referred to, as we see on the slide, as the AP. So whatever is added to the incident or outgoing ventricular ejection wave from the reflected wave due to arterial stiffness is referred to as the augmentation pressure. And this is a very important clinical index. From that is derived the augmentation index, or AIX, which is simply the augmentation pressure divided by the central pulse pressure times 100, which is expressed obviously as a percentage. And this is an expression of arterial stiffness. And the norms for these values have been established and vary with age, height, and sex. And one term not mentioned here that I'm going to mention is amplification of the blood pressure and pulse pressure. And amplification refers to the ratio of the brachial pulse pressure over the central pulse pressure. And this is an important value as well. And this generally in healthy individuals, amplification is greater than 30% as the systolic blood pressure tends to rise as blood vessel caliber diminishes with distally to the heart. And as we age, the amplification diminishes as well. So these measures, augmentation pressure, central pulse pressure, augmentation index, These are all important predictors of end organ damage and adverse cardiovascular outcomes. And in fact, in the STRONG Heart study, which was a study evaluating patients with various stages of disease, increased central pulse pressure was correlated in a linear fashion with adverse cardiovascular outcomes. And in a follow-up study, a central pulse pressure of greater than 50 millimeters of mercury was superior to all other indices in predicting cardiovascular events, superior to brachial pulse pressure and superior to all brachially measured indices. So how do we acquire the central pressure waveform with the SphygmoCor XL? Well, this process was validated in multiple invasive studies in the presence in both drug interactions as well as ambient states in multiple papers, and it received FDA clearance. It gets mathematically, the brachial pressure waveform gets mathematically transformed via a generalized transfer function to a central pressure waveform that is accurate to within 1 millimeter of mercury to a compared centrally acquired blood pressure. And the clinical utility of SphygmoCor has now been demonstrated in more than 1,000 peer-reviewed publications across all stages of disease. This is not some new technology. This is not something that has been some new kid on the block. This is a very established technology, very accepted hemodynamics in cardiovascular disease. So I think it's important to discuss, obviously, how this information will help you guide patient management. So we need to go over some cases and to show how SphygmoCor is useful in the everyday management of patients. I, as in my preventive cardiology practice, use this on every patient. I rely heavily on this device in multiple levels of patient management, whether it's guiding medication titration, diagnosing occult central blood pressure abnormalities that are not evident when you measure peripheral blood pressure. And so I think it's useful to go over some illustrative cases of various types of patients to further illustrate how useful the SphygmoCor really is, because I really wouldn't practice without it. So central pressure waveform analysis can really be used in multiple capacities to individualize care in multiple patient types. These are just some examples here. In pre-hypertensives or people who haven't displayed any brachial hypertension or mild hypertensives, we can use this to stratify patients into groups whether they need to be treated or not treated. We can decide to initiate therapy, to intensify therapy, or to actually change drug class therapy in younger patients or even older patients based on the central blood pressure, which has more clinical meaning than brachial blood pressure. In intermediate risk patients with hypertension, you can individualize your approach to medical management by taking medications, using them on patients, and doing follow-up studies to actually see how they affect the individual indices such as aortic systolic pressure, pulse pressure, aortic augmentation index, and that way you can know you're titrating your therapy in a rational manner rather than simply a surrogate manner that has not been really associated with outcomes as well as central blood pressure. And then finally, in complex cases, it's very useful because these patients are very challenging, often have big discrepancies between systolic blood pressure measured brachially versus centrally, and this can really aid in giving you confidence in knowing that you're managing them appropriately and aggressively enough or not overly aggressively. And so this all leads to improved effectiveness of your therapy and hopefully improved outcomes in your patients. So case one, let's take a patient who's a 33-year-old male, started on an ACE inhibitor for systolic and diastolic brachial hypertension 1 year before visit. And this patient is tolerating his medications, and his examination is essentially unremarkable. No real morbidities. Unfortunately, he doesn't smoke. So the brachial pressure on an average of 3 seated readings is 144/74. Not ideal, not terrible. His EKG 1 year ago was normal, and he's on ramipril, 10 milligrams a day. And given the fact that his systolic blood pressure is 144, there is a consideration to raise his medication due to his elevated systolic blood pressure, something that many of us would consider doing given that he's a young person and has a lifetime of exposure to elevated systolic blood pressure. So what we see here is his central aortic blood pressure waveform, and we see a central blood pressure of 114, and we see the normal range by convention of approximately 97 to 121. We see a central pulse pressure of 39 with a range desired of between 23 and 40. And we see an augmentation index of -7%, which is in the ideal range. So this person has no indices of elevated central pulse pressure, elevated central systolic pressure, which is significantly lower than his brachial systolic pressure, and his augmentation index, which is an indication of arterial stiffness, is nice and low. So this person has now avoided having his blood pressure medication increased, and he's encouraged to continue his exercise program, and 3 years later the patient was doing well on the same dose of ramipril. And I think this gives you confidence repeating this on a year-by-year basis, knowing that his actual end organs are not being exposed to increased pulsatile stress, and his arteries are not becoming stiffened. Once you see these things change, then you can add on a calcium channel blocker to the ACE inhibitor, or you could double up on his ramipril. Here's another case, and this is a display from the SphygmoCor device of a 72-year-old man with a brachial blood pressure of 135/59. Certainly nothing that would appear markedly troublesome or ominous to somebody on its face. And his central systolic blood pressure was 124 on the SphygmoCor measurement. However, the pulse pressure, which is, as I said, the pulse pressure is a primary determinant in multiple studies and physiologically of vascular inflammation, of vascular remodeling, and of poor outcomes, was 64. So that indicates a significant high event risk for cardiovascular heart failure, stroke, and myocardial infarction. Furthermore, the augmentation pressure and the augmentation index, as we see in the lower two panels or lines, indicate that arterial stiffness is taking place, and this is contributing to these abnormal measurements. So this profile suggests that despite a normal or lack of ominous brachial pressure, the central pressure was rather ugly looking, and this patient needs to be treated with likely an ACE inhibitor and plus or minus a calcium channel blocker to mitigate these augmentation effects of early wave reflections that are causing the augmentation pressure to go up, the augmentation index to go up, and subsequently the pulse pressure to go up. So here's an example of somebody you might see in your office, and you might leave them alone based on the brachial blood pressure, when in fact, again, beneath the surface of that iceberg, you're really dealing with a patient who's heading to a bad outcome, most likely. Here we have a patient who's 57, elevated systolic and diastolic blood pressure brachially, 146/92, and his central blood pressure is mildly elevated at 129. As we said, normal is approximately 122 to 124. But the augmentation parameters are low in this patient, so he's not really having any early reflected wave evidence, and therefore the stiffness indicators are not there. So his arteries are not suffering from any excessive stiffness. So this can help dictate your choice of blood pressure medication. Certainly I wouldn't shy away from using an ACE inhibitor or an angiotensin receptor blocker or a calcium channel blocker, but perhaps a diuretic may be an ideal choice for this person as well to lower the central systolic blood pressure, or a combination of an ARB or an ACE inhibitor with a diuretic, rather than maxing out an ARB or an ACE inhibitor unless you have comorbid conditions that would dictate, as per JNC 8 recommendations, a certain class of medications. again, very helpful data obtained from the central blood pressure analysis. Another case of a young female with a very ugly central blood pressure evaluation. She has a brachial blood pressure that's 154/94. And again, as we know, this does not necessarily correlate with poor central blood pressures, but she also has elevated central systolic blood pressure, elevated central pulse pressure, borderline elevated central augmentation pressure, and an aortic an augmentation index that's elevated as well. And her arteries are obviously stiff and contributing to an early incident wave, a reflected wave rather, and this person would benefit from vasodilators again. Again, I prefer ACE inhibitors and ARBs. Nitrate combinations may be beneficial, especially in African American populations. If you extrapolate out results of the AHEF study, you might consider a drug like Bidil in a patient like this if she's African American. But a diuretic would not be the drug of choice in this type of patient, certainly not a beta blocker. And let me make a point about beta blockers, and we'll see it in a later case. Beta blockers slow down the heart rate and therefore delay the incident wave. And what they do is they actually merge the incident wave with the reflected wave more frequently, thereby causing a higher augmentation pressure. This sort of explains why studies with atenolol and other non-selective beta blockers are associated with very worse outcomes than studies with other vasodilators. The central pulse pressure and central augmentation pressure are significantly augmented with beta blockers due to this timing phenomenon where the heart rate is slowed and therefore the reflected wave merges much more significantly with the outgoing wave. And we'll see another case of that after, I believe the next case might illustrate that. This is a very complex case of a 58-year-old African-American woman who has both diabetes and hypertension and a significantly elevated brachial blood pressure, 220/103. I'm certain we can rely on that. And her heart rate is 70 on amlodipine 10, a clonidine patch once a week, simple 2 milligrams a day, and also taking diabetes medication as well as a statin appropriately and aspirin. What we see in her pressure, central pressure measurements, is a central systolic blood pressure that is significantly elevated at 202. And if you look at the curve, you see a notch in the initial stroke and a marked augmentation of blood pressure in the central pulse pressure is significantly elevated at 98, and you can see that that is due to the significant augmentation pressure by reflected wave, and the augmentation index is 31%. So the treatment approach in this patient should try to emphasize vasodilatation while trying to preserve heart rate and elevate the heart rate to help prevent merging of the outgoing and the reflected wave, as I mentioned before, which occurs with beta blockers such as clonidine. So this patient was started on a vasodilating beta nebivolol. Clonidine was tapered and discontinued, and amlodipine was increased to 20 milligrams a day. In addition, spironolactone and hydrochlorothiazide to block the renin-angiotensin system further were added, and the resultant waveform, as we see, is significantly improved, and this is bound to result in improved prognosis. The brachial blood pressure went down, obviously significantly, but more importantly, as we know, the central pressure went from 202/104 to 111/74. The central pulse pressure, which, as I said, is a very strong marker and predictor of cardiovascular risk, both acute and chronically, went down from 98 millimeters of mercury to 37. The pulse pressure amplification went from 119% to 132, and we talked about what amplification means earlier, and the augmentation index went from 31% down to 20%. So this case allowed us to use the central pressure waveform to guide treatment decisions to achieve both brachial blood pressure reduction and a desirable central pressure profile and central profile reduction as well. This study I like very much. It was a study called the BP Guide study. It was a small study of 286 patients looking at how central blood pressure guided hypertension management alters clinical management of patients in a community-based setting. And it basically randomized people to either be treated with conventional management absent the SphygmoCor device or utilizing SphygmoCor alongside with conventional management. And those people who were randomized to central blood pressure management alongside standard management had a marked significant decrease in the amount of medications they were taking and improved quality of life and decreased aortic stiffness. Importantly, despite taking less medications, these changes occurred, and there was a trend towards improved LV mass indices on the group that had the SphygmoCor management. Again, less medications. So they were over-treating the people in the group that was not managed with the SphygmoCor. Interesting study. So in summary, as we've seen, there is a wealth of data and science supporting the fact that central pressure waveform analysis gives you important information to better inform hypertension management using existing guidelines, and assessing individual patient physiology for directed care is very important, and central blood pressure is a far more physiologically relevant parameter than brachial blood pressure is. Management of patients in whom treatment decisions are uncertain helps much more effectively, in my opinion, and I think is based in the study results by central blood pressure analysis. And measuring differential drug effects and titrating therapy individually is much more easily attained by using central pressure waveform analysis. Understanding the effect of arterial stiffness on patients' physiology and wave reflections is helpful in diagnosing and making treatment decisions, and these are directly related to patient outcomes. And again, these pertain to decisions to initiate, intensify, or change therapy, the choice of antihypertension agents to be used and the regimen and how aggressively to use them, and the assessment of the therapy effectiveness and the direction of further treatment. As I said, and I'll try to reiterate this point, peripheral blood pressure or brachial blood pressure is an ineffective and poor surrogate of actually what is happening in the end organs in the body, and central blood pressure, to me, is an essential tool in dictating and making treatment decisions about patient therapy, both with hypertension and without overt brachial hypertension. So with that, I can open it up to questions, and I thank you for your attention. Oh, I forgot one more slide. SphygmoCor is now reimbursable under code 930, and it is classified under waveform analysis for assessment of central arterial pressures, including obtaining waveforms, digitization, and application of nonlinear transformations to determine central arterial pressures and augmentation index with interpretation upper extremity non-invasive. And if you could say that really fast, you're better than me. So with that, I'll hand it back to Mary and open it up to questions. And again,
Thank you, Dr. Marcus. We're going to open up the questions now. Read the question.
Okay, first question is, how has incorporation of SphygmoCor impacted workflow in my practice? That's an excellent question. SphygmoCor has not affected my workflow one iota. It takes about 10 to 15 minutes to do a study. The patients sit in front of me, and I actually like doing it myself rather than my nurse. And I sit and talk to them while they're doing it very quietly. They have to be calm, but they can talk quietly. And really, the machine measures three sequential blood pressures several minutes apart, and then it measures the central arterial waveform. The report is printed out. I can hand out an explanation to the patient of what the report means with their numbers so they can take it to their primary care doctor in case, because a lot of primary care doctors are not really aware that this technology exists, and it doesn't slow down my patient flow at all. In fact, it provides me with a nice opportunity to interact with them, to discuss what central blood pressure is and how it's really different than what you're normally seeing in a doctor's office. So I think it provides an opportunity to educate, and it doesn't slow down my patient flow whatsoever. So the next question is, how long does it take to see changes in central blood pressure, and more importantly, augmentation index? Is 1 month enough to detect a meaningful change? The answer to that is generally I can see changes in a month with changes in medication classes. I have a recent patient who underwent 5-vessel bypass surgery, came out of the hospital as surgeons are wont to do. They put the patient on a high dose of metoprolol and amiodarone for some post-op AFib, was on a teeny dose of an ACE inhibitor, no calcium channel blocker, and the patient saw me and their peripheral blood pressure was excellent, but their pulse pressure was actually 70, central pulse pressure, and their augmentation index was very elevated. I weaned them off the metoprolol and I stopped their amiodarone because they were in sinus rhythm. I doubled up on their ACE inhibitor, lisinopril, to 10 milligrams a day, and I added amlodipine 5 milligrams a day, and a month later their indices were actually totally within the green, all within normal limits. So they really, I saw a significant change, which I think is going to be prognostically significant, almost less than a month. Okay, and another question is, what instructions, for example, fasting, do I give to the patients to follow prior to coming in for an assessment? And if I do not follow the instructions, do I postpone the measurement? Well, interestingly, unlike other forms of vascular health measurements, such as the endopat, which requires certain preparation and food requirements, I don't really limit them. I don't caffeine before they come in, but other than that, I want them to take their medications before they come in. They don't need to be fasting. I just like them to sit there calmly for 5 minutes or so before the test, and so they're not anxious. We do measure 3 measurements about 2 to 3 minutes apart during the test, and I have never had to postpone a measurement. And I like the machine because it gives you an indication of whether you did the assessment properly or if numbers are not valid. It does a self-calibrating check, and it gives you a check mark whether the curves are actually acquired properly. And I've never had one patient's numbers thrown out or tossed because they were not acquired properly. I've never had to repeat a test on somebody. So it's one shot, get it done, the numbers are there, and then I'm able to discuss the numbers immediately on the screen with the patient and what they mean. And so there really is not a problem with preparation for the testing. So a last question, do I use Buchberg, SEVR, or ejection duration in my clinical work? Occasionally, so the SEVR is the amount of time that the coronary arteries have to fill during diastole, and it's reported in this with the SphygmoCor machine, basically as derived from the indices that are acquired during the blood pressure acquisition. And so obviously, the more afterload and higher the stiffness of the arteries, the longer the heart is squeezing, and for the less time it serves in diastole, uh, uh, being able to fill. And so it's basically the intraventricular pressure is going to be higher, and so SEVR is sort of a measure of the ability for the coronaries to fill more adequately. But I don't really use it generally on a regular basis. I'll glance at it, but I won't use it as an endpoint to titrate therapy. I use the main indices that have been studied most frequently in clinical outcome studies, as I mentioned in the presentation.
Okay. Thank you, Dr. Marcus. That's all the time we have for questions, but I do want to let people know that if we didn't get to your question, we do get a list of those at the end, and we will respond to those individually. And I want to thank Dr. Marcus for a wonderful presentation today. Thank you for your time and your informative presentation, and we hope everyone has a great day. Thank you for joining us.